Good. Perfect. So I would like to introduce Dr. Shannon Jackson. So I think many of you in the crowd know Dr. Jackson. She is the medical director of the Provincial Adult Bleeding Disorders Program and co-founder of West Coast Hematology, practicing at St. Paul's. And she's also a clinical professor of medicine at UBC. Dr. Jackson is also passionate about measuring health outcomes that matter to patients and transforming to a value-based healthcare model of care. And currently, Dr. Jackson is working as the physician lead for value-based healthcare at Providence Health. So I'm going to stop my screen share so that Dr. Jackson can start hers. And thank you so much for agreeing to present to us today.
Thank you, Krista. As I just get my slides up here and find my presentation, I think we're here. Sorry, that's not the right one. Krista, help me out. What do you see, if anything?
I see your Zoom. So do you have
Let me
two
just stop
screens?
share. No. I think what happened is, pardon me, let me just try again. We practiced this in everything and it worked, but here we go.
There we go. Awesome.
Yeah. I think this is much better. So thanks
Perfect.
so much. I'm hoping to talk for maybe a little over half an hour and leave time for questions. This kind of stimulated from work that has happened with the sort of PQI, so physician-led quality improvement, and integrating some value-based healthcare into the curriculum. So super thrilled to be able to talk here. And I think some of you I've spoken about this, but hopefully today I can give you a bit more of a broader context. So the three big things that I wanted to do was introduce the concept and sort of the ideology of value-based healthcare, talk about how it intersects with kind of that model of improvement and measuring for improvement. And then most of all, get into like, what about the practical stuff? What can teams do to start collecting and acting on outcome measures? And I wanted to bake in a little bit of hematology and transfusion medicine where I could. So let's start with really my origin story. And to sort of preface that, today is World Hemophilia Day. For those of you who didn't know, it's every year on April 17th globally. This whole World Federation of Hemophilia was actually started in Canada by a fellow named Frank Schnabel out of Montreal. And today the global organization is still based in Montreal. So yay, Canada. And we're going to make hemophilia a bit of a theme today. So it's really how I started to realize how important, at least to me and most other clinicians I've met, the outcomes that matter to patients. So years ago, we had some not great outcomes in our severe hemophilia population, many of whom had knee and other joints that looked sort of like this. And they were highly disabled, severe end-stage arthritis after a lifetime of recurrent bleeds, leading to pain and mobility, hospitalizations, and also admissions to hospital. And when we started measuring, we had bleed rates in each individual that were really high. And we were attempting to use what was then safe recombinant factor therapies that had come through the amazing feats in the transfusion medicine era, moving from plasma derived to recombinant. And yet we had this product that patients were supposed to be using to prevent this kind of stuff, and we were still seeing it. So we weren't getting great outcomes for the cost we were spending in product. And what we did as a team a number of years ago is really align, gain a measurement strategy, work together with what we had to facilitate an improvement in outcomes. And the medical condition was severe hemophilia A, a small population. And this is what we saw. So we made this graph into 2015. After we did this for a number of years, and Krista and I were speaking at the beginning, it takes a long time to have these things change. But you can see for this cohort of 42 patients, their cumulative bleed rate with no special intervention or technology or new treatment decreased quite substantially just when we aligned on measurement and engagement and a number of other strategies. So each patient was having 12 to 13 or more bleeds per year at the beginning in 2010. This was down to 1 or 2 per year in 2014. And the graphs below, although a smaller number of patients, show we were able to maintain that, and we still do today. So that's the outcome side. But of course, we wonder, well, at what cost? The easiest cost for us to measure, and we often measure the easiest thing we can get a hold of, was the cost or the amount of factor VIII concentrate used during that interval. And between 2010 and 2014, we only used 3% more in those same groups of patients. We were taking what they were using already and using it better and smarter and getting better outcomes. This was the hook for me that day that we looked at this. And then I did some more, when I learned about value-based healthcare and learned some more sophisticated ways to look at cost, we began to think about what is the cost of being able to see less patients in clinic because they're at home doing well, and being able to have increased capacity and more ability to see patients in clinics. So we did this methodology called time-driven activity-based costing. We looked at the composite cost of care in 2011 versus 2020 for things like factor, humans, and supplies. And then we looked at how many patients we were able to take care of. And you can see that the cost remained relatively stable, if not lower, between 2011 and 2020, but we were able to care for more patients. So almost that opportunity cost of being able to do more with what we had. This was kind of the preface to like my origin story and why I got into this. So what value-based healthcare ideologically looks at is designing a health system or a metric to look at how we might improve care through a lens of measuring and achieving outcomes that matter to patients. So we'll get into that in a few minutes, relative for the cost required to achieve those outcomes during the patient's journey. It's all predicated on patients who have a similar medical condition or a set of medical conditions, or even things like a healthy pregnancy. And the intention is that you don't calculate a number for this. It's not cost utility analysis, which is kind of the opposite, cost per outcome, but you don't improve value just by focusing on costs alone. So this sort of ideological view is great, and it was described about 20 years ago, actually, by Michael Porter and Elizabeth Teisberg. I've had the privilege of learning from both of them, from being trained in Harvard by Michael Porter and then doing my master's with Elizabeth Teisberg. And there's been a lot of evolution over the 20 years in sort of the ideology. They had 6 sort of major points that they kind of challenged health systems to take on. They're not doctors themselves, so they have a bit of a different business strategy, competitive view. But really, they said that legacy healthcare has a problem 20 years ago because we tend to organize ourselves not around patient conditions, but around specialties in organ systems and departments. And we tend to focus how good or how much progress we've made on the volume of cases we see. They challenged us to reorganize healthcare, thinking about condition, thinking about patient groups who have similar needs, no matter where their specialties or departments come from. They also called out healthcare, and I can't say we're a lot better 20 years later, for really relying on process and compliance as surrogates for health outcomes that matter. And they challenged us to begin to design systems that can measure outcomes and costs for every patient. And finally, recognizing that even back then, and to some extent still now, we have these siloed, non-integrated, non-interoperable IT systems that can't communicate data. So they said we have to work on that in healthcare to integrate these things. And there was other principles, but these were the ones that really stuck for me. This also stuck in the medical literature. So Redefining Healthcare, published in 2006, late 2006, began to see publications in the New England Journal, Annals, like it really kind of started to hit the high quality medical literature. And then an organization that we'll talk about a little bit later called ICHOM, this is the International Consortium of Health Outcome Measures, founded in about 2012, 2013, really kind of set off the number of medical papers and descriptions of value-based healthcare implementation. And this graph only goes up to 2019, but I can guarantee you it continues to increase. One of the challenges that I've certainly found with the ideology and with that word value is that it's very ambiguous. So value tends to mean different things to different people and different stakeholders in our health system. And what we have observed over this last 20 years is a little bit of dilution in some cases. So what we mean by value relates to that equation or that relational thing between outcomes and costs. But what often can happen is that authors with good intention kind of use that word to imply things. The biggest example I can think of is when we see things like choosing wisely, which are amazing. They're super important and they're intended to improve outcomes, but they're not actually measuring that along with cost, but they're very valuable. It's just not value-based healthcare in how it was set forth. And when a paper a few years ago really took a look in 2015 at the medical literature and looked at where the authors were citing, if they cited these key New England Journal Annals papers that were the core of value-based healthcare, only in about 25% of times were they actually citing their paper that was representing what the principles of value-based healthcare were really outlined. So there seemed to be this dilution and this sort of labeling of other things. And I've certainly seen that in many implementations, and it's well intended. I think the main thing is to remember that at its heart, it's really an improvement effort, a transformational science for healthcare. So to set the stage before we talk a little bit about value-based healthcare, quality improvement, and research, this is just like a super simplistic, almost cartoonish look at what happens when we have a patient who presents with some kind of need. It may be a condition, a group of them, or presentation, and they come to care in whatever setting this is, and stuff happens. And we measure some of that stuff. But really, we're talking here about what do we achieve? What are the results? What are those health outcomes? And what we may think of in the most simplistic way is that some of them can be reported by patients, and ideally should. They're really the ones who can portray with respect to the condition or symptoms they have, whether they're better or not. Or in some cases, we need to report them as proxy clinicians. So they may be clinician reported, but the data is extracted from patients using methodologically rigorous, psychometrically validated patient-reported outcome questionnaires. So this is a science that's well established and has progressed over the last 20 years to allow us to measure what we think we're measuring. The other kind of big group, and one that will be very familiar to this audience, is those standardized endpoints that are often in the medical literature. You know, at the most simplistic, mortality, did you die or not? If you didn't die, what is your state of health? And many different ways, depending on the publication or the organization or the intent of how we might measure that at a particular point in time. So examples might be cure, remission, relapse, overall survival. So those are the sort of big picture health outcomes. And ideally, we'd have more of those at our fingertips on an everyday basis. But unfortunately, in healthcare, we really don't. This is another kind of simplistic measure to sort of pictorially outline that in healthcare, it's not like we lack measurement or data. We're absolutely drowning in it, but we tend to have the kind of data in the stuff happens category in the middle. We have a lot of process metric data, and not to say it's not important. It's actually crucially important, but it's much better when it's paired with the relevant health outcomes. Process measures are things like the volume, the time, or the proportion of things. They're those really important things. CIHI has a lot of them, and I'm not saying they're not important. The other kind of big category is the systems need and want to do no harm. So to detect, remediate, and prevent safety and adverse events. Again, really important. And then the other kind of big metrics, particularly that bottom one where it says system quality, clinical measures, and cost metrics. I made it in blue on purpose because it's like a sea of measures. As a hematologist, I look at thousands of them every day in terms of clinical measures. And I also can look at system quality measures. But rarely in Canada do I really get much of a actual numerical report on cost metrics. It's a little bit harder in a system that's globally funded. And then on the top, patient-reported experience measures. These are the kind of sector surveys that look at how were you treated when you came to interact with our healthcare system. They tend to be a lot about how did we do as a health system? How could we do better? But that's different than when we're asking a patient, a PROM in the health outcome category. How are you doing with your condition? And I think one of the things Porter and Teesberg really both point out is that there's no fault on the part of any clinician or healthcare worker. We tend to measure what we can and what we directly control. vis-a-vis my origin story. We measured bleeds. That was the data we could get. We measured factor utilization. That's what we could get at the time. So it's easier to measure and feasible, but it's not always what really matters to a population or an individual patient. So let's talk a little bit now about sort of this category of performance measurement. I think of value-based healthcare as one of the important ways health systems can look at performance measurement alongside and interacting with quality improvement and research at times. So quality improvement, big science. I know Krista's doing some training, and it's absolutely an amazing way to use a structured method in science for making decisions about what change to make, implementing it, and then measuring whether we've made iterative changes. Focusing mainly on processes and indicators as primary measures. Of course, thinking about balancing measures, those things that are the maybe unintended or not or anticipated impacts of those changes, but by nature, the quality improvement science does not necessarily include health outcome measures in every project. I love the PDSA cycle, so Plan, Do, Study, Act. This is a core tenet of improvement science, and one that I think a lot of people are familiar with, and certainly in value-based healthcare can be a really critical way we can work with teams to improve. A lot of us here have done research. Again, really important to use standardized, rigorous design methods. Typically, research projects are going to be shorter, tied to funding cycles, and they tend to concentrate on a specific question and then, of course, try to control other variables to really be able to detect a meaningful change. And in that, it often is a mandatory thing to exclude certain populations and limit the types of populations studied. An option in some studies is to include some of those psychometrically validated questionnaires. We kind of call them the quality of life measures, and we often add, 50, 60, 70 questions onto a visit to capture those things in research. And where possible, research is co-designed with patients in mind so that those questions can be relevant, but not in all cases, that does not necessarily happen. Where value-based healthcare kind of fits is drawing upon some of those quality improvement methodologies, but inserting a focus on health outcomes. But the relevant key measures that are process, safety, complications are also created in more of a measurement set that's relevant for patients for that condition over a continuum of their care, which can vary between a day and a lifetime in some cases. And we really want to think about the measurement across multiple settings, which is unusual, especially in an acute care sort of focused quality improvement landscape. One of the critical things I wanted to mention is that looking at things this way can really highlight and identify gaps in care where patients are not able to achieve the outcomes because of a limitation or a fragmentation. And probably most importantly, and the one thing I want to take away from this slide is that this is a critical way of being able to look at health equity. When you start to focus in on health outcomes, and particularly those that matter, you start to see the inequities in how different groups of populations receive the benefit of healthcare, or in many cases do not. And that's, I think, something that research can not necessarily do unless they're focusing on a population like that. And it's something that both value-based healthcare and quality improvement can really improve from. Because we all know, no matter where we are in that spectrum of improvement, anytime we measure it and look at it, it improves. And actually, we can see it improve exponentially. In my origin story, we started with that graph, but that led to measuring pain, because pain actually matters more to patients than bleeding events. That led us to think about, well, what about impact on vocation? What about impact on social functioning, on mental health? So it starts to kind of seed itself and look towards what really matters. And that was the really fun part of that journey for our team. Let me give you an example. So this is a little bit of a hybrid of some research and some measurement. And what I want to get out of this is two things. So we're going to talk about the equity part, and then we're going to talk about the impact of doing this on teams who do it together. So in the top right of the slide, you can see kind of a general change in health outcomes and a magnitude of improvement on this axis. What we want in health systems, when we realize that not everybody in our population is going to start at the same level of function. And there's many barriers to so many populations. What often happens is we don't measure the health outcomes, but if we did, we would want to see that that's this middle column where the people who start out at a worser function due to features that are not necessarily related to the treatment offered or the condition itself medically, we want to see their outcomes get better to the same degree as we do the rest of the population. So we narrow these initial health gaps that start. Often, I think it's the opposite that happens. We either have a neutral or equal improvement for both groups, or worst case scenario, because of our intervention and solution that creates an advantage for other populations, those who have more privilege, et cetera, get a better health outcome than those who don't, and the gap widens. So this was a study I want to show you next, done in Boston by a group who do knee replacements. So they're doing total knee replacements on all comers. And what they decided to do was take a standardized PROM, so a patient-reported outcome measure that's very, very much well-known and validated in this sort of pre and post knee surgery. Most of the time we'll do it before and maybe once or twice after in routine care. What they did was they measured it in like weekly for a whole year. So they accumulated a lot of data, and they paid careful attention to making sure that they had a look at two kind of variables that had an impact on how people did, or so they thought. One is gender, male or female, biologically. The other is Black or white patients that they see in their population. And this is the graph that they were able to show over a year. So the PROM score is depicted over time. And you can see that not every individual who falls into one of these categories starts at the same place in terms of their function before surgery. They all have surgery, and they all have these measures done once weekly over time, and they all kind of improve. But not everybody gets the same level of function as the other individuals. We don't see this narrowing gap. And there's lots of questions that I'm sure you're thinking, as I was when I looked at this graph. And the point being is that unless we measure health outcomes for everybody, and we have to sometimes work really hard to do that in some populations who may have health system distrust, who are not able to come to clinic as many times as others or afford certain treatments, the more we do this, the more we start pulling together as a team and looking for solutions. And that's why I show this slide, is that measuring together as teams and looking at outcome data, and in some cases also other types of data, process data, safety data, blah, 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 but it can really start to align us with more precision on what we're trying to accomplish. And this is exactly what happened to us when we started to work on those hemophilia bleeds. We became laser focused and involved the patients in the measurement as well. As I feel we became more like the formation flying on the left. And we started kind of like many teams, like the formation on the right. We were generally going in the same direction, but we didn't have kind of that information to really guide us. And we weren't working together as ideally as we could otherwise. So we're going to transition a little bit, and I'm going to talk a bit more about how do we know what health outcomes matter to patients, like for a level of medical condition. We didn't know when we started the hemophilia journey what to really start to measure other than bleeds. And then I'll talk a little bit about costs. So that ICHOM organization that I mentioned in that very early slide that started in around 2012 or 2013, they were established for the specific purpose of bringing together methodological experts, patients from the globe, and also expert clinicians from the globe to design these measurement sets that reflected health outcomes that matter to patients, but also some of those complications, some of those process, and some of those sort of survival or state of health kind of questions. And they published this free, so it's online. Through the ichom.org. And I show you here this kind of wheel of outcomes. And it's designed after Codman, who was like a pioneer in quality improvement, who always wanted the patient to be at the center, and then what was measured to be around it, like this wheel. And so you can see that there's a lot of things here. Fully in the blue little kind of boxes here, those are the patient-reported outcomes. So nearly half of the outcomes that are recommended are patient-reported, which is it's different than how health systems typically operate. There's a lot of other resources that are available on the website that guide teams through what instruments they may use, how often to measure it, et cetera. But my other point is that not everybody can start measuring everything all at once. Everybody who does that fails. So we often have to start slowly and measuring just a few key things at the beginning. What if you look up on iChum and for your population, and there's nothing there for your population? This happens a lot. There are many more rare conditions, such as hemophilia and others, that the global organization simply hasn't got to yet. Well, it turns out that after about, again, a couple of decades of research through Elizabeth Teisberg's group, that many health outcomes across chronic conditions, especially, they tend to be quite similar for patients. They tend to matter to a lot of groups of patients. And they came up with this little bit of a tool to help us think about types of health outcomes that really matter to patients. And they tend to fall into one of three categories. They tend to reflect the capability of an individual to function either physically or cognitively. We call these the kind of functional outcomes, and we're quite used to those in medicine. We know there's lots of ways we can measure it, and they also are important to patients. So that's one category of when you're trying to think about what things to measure, that would be important. For the hemophilia example, it became vocational capability, it became physical capability to play with kids, to do things like exercise, to have the mental capability and not be in pain, interfering with your ability to function as a parent, for example. The middle category is the comfort. That's a lot of the reason why many of us went into healthcare, is we want to relieve physical or emotional suffering. And this is the sort of category or grouping of measures that reflect that. So in our hemophilia group, it was, simple chronic pain or acute pain, that type of thing. And sometimes it could be anxiety to bleed or anxiety to participate in sport. The latter group is a bit interesting and came through a lot of hundreds and hundreds of patients, and there are some publications on this. They reflect a group of measures that reflect the ability of a patient to not have their life consumed by medical care, by multiple appointments, multiple repetitive, sometimes duplicate laboratory or specialist evaluations that don't need to happen. So that in the end, a health system that creates value for patients provides a less disruptive and chaotic experience. It's not about the experience of how much they liked it. It's about being able to actually live their life while receiving care. So I thought I might just showcase a quick example that we did through our value team at Providence in how we might figure out what are these three C's: capability, comfort, and calm. We actually have to meet with patients and ask them, what is important, and tell us about your condition. So we do sort of facilitated, almost like focus groups, except the agenda is quite open, and we record them and we thematically analyze them when we come up with concepts and themes that sort of resonate with this population. So we did this for chronic shoulder pain. So patients who have chronic shoulder pain for more than 3 months, they were part of a clinic that was a new clinic designed to kind of decrease their wait time to see a surgeon. Because historically, everyone got kind of routed in to see a surgeon and spends 2 or 3 months or 2 or 3 years, on a waiting list while their shoulder continues to deteriorate it because they're in pain and they don't want to move it. So a new clinic came up to introduce the idea of early physiotherapy and intervention, and maybe avoiding entirely an orthopedic surgeon visit for those people who wouldn't really get any value out of that interaction. So we met with people with chronic shoulder pain, and they told us some of the things that mattered are reflected in this little figure here. So under capability, things that aren't surprising: being independent, being able to participate in family social activities, earn a living, easy. Under comfort, no kidding, they don't want pain. They don't want to be worried that it's going to worsen if they start to do things. And then that calm piece, not being on the waiting list for 3 years, not sure if they're going to get surgery or not. And then when they do come to care, not having a clue what to do, when, where, why, or how. So this was a really big theme for these folks. So our value team takes these, and then we try to derive them into what could we measure? What could we actually measure to reflect a health outcome at baseline and then after the care treatment? And so we sort of refine this down into what might be feasible in a minimum of questions. It's going to take less than 5 or 10 minutes. And then we come up with, for the team, a recommendation on here's what you might consider measuring, here's how often you want to measure it, and then therefore they set off and begin to measure. And the clinic is called the Rapid Access Shoulder Clinic, and this is a functional clinic at Providence doing this work. We also then, after interviewing the patients, you learn a lot of things that you don't realize through your provider lens. And so we needed to take that and understand the patient side of the journey. And through that, we were able to design kind of a pre-clinic handout that really explained the purpose of the clinic, most of all, because it was so different than what people come to expect in healthcare. And secondly, we were starting to ask them questions about their symptoms, which is not usually done. So explaining why we were asking these questionnaires before they came to see us and also after. And then we didn't forget about cost. I haven't talked about cost to a great degree, but remember that's the denominator here. So we want to think about the cost of what we're doing. And so for the Rapid Access Shoulder Clinic, we also did that. Well, we always, though, focus on outcomes first, because if you get that right, the cost then follows and seems to be less. So we did a similar methodology that I mentioned in the hemophilia example called time-driven activity-based costing to look, again, at what costs we could easily get throughout the continuum of care for those patients. And this was a relatively short one because they saw us over a relatively short period of time, a few months. We also looked at opportunity cost that I showed you as well on the hemophilia example. What could better care translate into in terms of system capacity? How many more patients could we take care of if we actually put the right patient in front of the right clinician? And for this example, it was exceptionally important that we could then get patients in front of the orthopedic surgeon who really needed surgery, and those who never would in front of a provider who could help them faster with more time spent. We can also, though, think about measuring costs from the perspective of the patients. Travel cost, days of time off school or work, parking, all of these things that we don't necessarily always consider when we're ordering tests, particularly for outpatients. So we do have tools that can use that. We didn't do this in this example. So what we did after doing some detailed process mapping is really look at both another outcome, which is more to do with wait time, more of a calm outcome. And we were able to measure that this model actually reduced the time for those patients who didn't need to see a surgeon from 2 years down to 7 months. And within that, they were able to, and the health outcomes that we're measuring are able to look at, well, what did they do in terms of capability, comfort, and calm? And then our time-driven activity-based costing, comparing the old pathway to the new one, turned out that this was about 5 to 10% cheaper. However, inertia is a huge thing in healthcare. And so when we have an example like this, it's like, well, why can't we just do this everywhere? And I think the huge challenge that many of you who've worked on improvement projects, and certainly something that we struggle with, is the system kind of moves on its own. And we have a big healthcare behemoth marching forward. About 20 to 30% of the costs that are spent are probably not ideally spent. There is waste in our system, but to actually get in and change those wheels is not as easy as it would seem. And so I'm kind of here as a proponent of really trying to really change this and begin to get those wheels of quality, value-based healthcare, measurement for improvement outcomes, and research aligned together. This is where I'm going to focus back a little bit on hematology and a slightly different example that's more contemporary to the one I showed at the beginning of the talk. We're going to talk about something quite different. This is acquired hemophilia A. The first slide was congenital hemophilia A. That tends to be diagnosed in childhood or much, much, much earlier in life. Acquired hemophilia, on the other hand, is something you weren't born with. It's the development of these neutralizing autoantibodies against coagulation factor 8. And unfortunately, the biggest peak is seen in folks who are older, typically older than 60, although we do see some around pregnancy and postpartum phases. The number of cases is quite different from the congenital hemophilia. We probably have 500 and 600 patients in BC ballpark of that, whereas we only see one or sort of 5 to 10 cases per year, we think, in British Columbia of acquired hemophilia A. The population incidence is about 1 to 2 cases per million per year. And our effort is really, as hematologists, to identify this, and we partner strongly with our coagulation and other labs across the province to do this. once diagnosed, treat the bleeding with bypassing agents historically that again, many of our transfusion medicine colleagues are helpful to ensure we have access to, and then we eradicate the antibody where possible and are pretty successful in about 80% of cases or more. Historically, this population was not cared for in the provincial program. Population is cared for by individual hematologists who may see a case every few years without really the ability to have a larger guidance on what to do best practice-wise. So a few of us who are working in the lab and also in the clinic with respect to the inherited bleeding population wanted to kind of maybe take this on through a bit of a value-based healthcare lens. We knew we had some known unknowns. We didn't know what outcomes we were achieving in the province in terms of mortality, how many patients were relapsing, how many were stable, and more importantly, how were our patients functioning? We did know that from the cost perspective, these patients spend a lot of time in that upfront control the bleeding with bypassing agents in hospital. So they have a lot of upfront hospital times. We also know that tends to create frailty, iatrogenic complications, weakness, et cetera, et cetera. It's not the best place to rehabilitate. So we knew that conceptually we didn't have a knowledge of our outcomes. Maybe they were good, maybe not. And we knew the costs were expensive. So we decided to kind of step back and say, well, what would an acquired hemophilia A value project, value for patients and value for the system look like? We knew we had to standardize the measurement and begin with really trying to probably decrease the package of initial investigations, try to prevent it happening repetitively, and also really look upstream. And that's where I credit this group and the Provincial Transfusion Medicine group with taking a look at that first elevated PTT and how can we enable and facilitate the diagnosis happening earlier. Because these patients often have weeks of bleeding before recognition that something's actually quite wrong and the ultimate investigation is done. Then we wanted to standardize the monitoring tests, the response criteria, and most importantly, add those patient relevant and clinically important measures to care. We also had a bit of a opportunity because we could optimize existing approaches to both bleed treatment and prevention and eradication. But we had this new novel therapy that was showing huge promise, not only in congenital hemophilia, but now in acquired hemophilia to really get these patients out of hospital faster, called emicizumab or Hemlibra, that finally became available for us last year. And we wanted to ensure that patients were cared for by a smaller group of clinicians who could keep track and measure and follow them up in a more consistent way. These were some of our intents and components, and we developed this care pathway with multiple stakeholders that would take part in it, listed on the left there. There's more, but this is kind of just the essence of a lot of people that have to work together as a team. And then in general, we have this kind of phase across the top, that diagnostic phase in blue, and that early phase where we're trying to control and treat presenting bleeding. Historically, it would take a 20 or 30-day hospital stay to do that with intravenous bypassing agents. What we wanted to do is get control really early on and aim to keep them in hospital as little as possible and try and improve their functional status by just avoiding that hospital lesion of immobility, rebleeding, interventions, and often infections, and then follow them through the outpatient phase where we're still working on getting rid of that inhibitor. It takes several weeks of immunosuppressive therapy to do that, sometimes months. So we developed kind of a clear process map, not going to go in the details here, but really clarifying who's going to do what, how are we going to make this happen, and how do we facilitate this happening fast and more in the outpatient setting than in the inpatient setting, while we simultaneously work on that upstream stuff. How can we communicate and identify these patients faster and better? So we now are using emicizumab as soon as we can get access to it, ideally within a day or two of hospital admission, and it's awesome. It really decreases that early bleed quite quickly, and we're able to get these patients off of bypassing agents and then transition to their own prophylaxis at home. So far, we've had 4 cases, in about 3 of them, we've had excellent control, and 2 of them were out of hospital within a week, and 1 remains out of hospital. Never got hospitalized in the first place. So we knew that there was some outcomes we might want to measure that mattered to patients, but we didn't do interviews. There's just too few of these patients available. And we think that some of them have to do with, of course, survival, but also, avoiding complications, but minimizing pain, anxiety, dependence on others, inability to return to the same degree of independence or living situation. And of course, thinking about the testing after discharge and trying to minimize that for both the patient and the system where possible. We know there's many costs that the system incurs in addition to those the patients incur. So really thinking about measuring some of those things as we go forward. The health status measures we selected for the prospective phase. So we began doing this in July of 2024, although most of our cases have been late December through now. Were simple. So looking at scales that can be done quickly without burden on clinicians or patients. So we're using 3. One is a frailty scale. One is EQ5D, which is a sort of qualitative scale that's generic, not specific to this disease. And then the ECOG, which is very familiar to most hematologists. So we starting to measure those aspects from patients. What we did was we wanted to benchmark what has happened so far. So what are the outcomes we were achieving before this new pathway? And that's from January 2018 to December 2023. So we have a wonderful group of trainees, Nick Chernensky, Kate Levitt, Kate Preston, and they're working, and we had a summer student last year, Andrew, working to collect this data. So we know what we were doing before. And we're not totally done yet, but we will have as close as we can get to provincial data. And then we're prospectively wanting to collect the measures that I mentioned already in a kind of standardized way going forward so we can evaluate how our performance looks. So I hope that in the last kind of 40 minutes, I've been able to give you a sense of the ideology of value-based healthcare, how it interacts with quality improvement and research, really to look at performance improvement, and then recognize the potential for what teams can do who come from all different aspects of care to start collecting and acting on health outcome measures. If you're interested in learning more, feel free to email me. We also have a value-based healthcare email at Providence. And ICHOM actually has done an amazing job in the last year of allowing opportunities for people to learn with global colleagues in an online format. It's excellent, and you really can learn a little bit of how to, particularly if you were thinking about this with a team. And there are some really great books, particularly how to measure health outcomes. It's a small little pocket book. And then patient priority is quite good too. It gives you a little bit of a fill-in from the last 20 years since Redefining Healthcare was written. And with that, I think I'll stop and be sort of really thrilled to hear your questions or comments or suggestions.
Thank you so much. That was fantastic. I just want to compliment you on your amazing swim lane process map. They are my favorite. So, and usually don't see them in presentations, but love the colors, and it just really helps to, show the process. There's already one question in the chat from Sarah Teesing. Is there a way for us to develop the measurable outcomes based on a patient experience by using a software or program?
Yeah, I'm curious about the question a little bit more. I don't know if Sarah, you feel comfortable if you're thinking about kind of AI. Yeah, please. I'd love to hear what you're thinking.
I'm just thinking of things like, from the way I understand your process works, it sounds to me like you will say, okay, this is something that needs to be measured better in terms of patient outcomes. You will get patient data, which could be qualitative data, which could be quantitative data, like it could be a mix. And then you bring it to your team who says, okay, this is the outcomes that you can develop based off of that to really assess objectively your practice or any improvement measure that you're putting in, right? And I was just wondering, is there a way, like almost like, you're right, almost like AI, like if I can go on a software and put like, this is my patient's experience, this is what we are trying to do. What are the potential things I can measure? Like something which will simplify the process, so to speak.
Yeah, you nailed it, Sarah. Absolutely. I mean, now we kind of we try to look in the literature, the sort of various quote unquote medical literature to see if there's been publications often, especially when we're working with a big population. But I think one of the untapped places are the places in chat groups and Reddits and Facebook groups and stuff, because there's patient experiences in there and reflections on things that would come out through the capability, comfort, and calm that probably are going to be synergistic with what we hear when we bring a selected group of patients together, or we look in the medical literature. When I did my master's, we did a project on chronic myelogenous leukemia, and we partnered with the Canadian and the American kind of patient group, and they gave us access to their closed Facebook group, so a team member with permission, and we were able to extract some really interesting things from there. So I actually agree. I think it's a powerful tool. I don't know how I would use it, but I sure hope that we can mobilize in the most respectful way when patients are sharing these perspectives, that we want to listen to them and where possible adopt them into care. Some of it is going to be a little bit out there, but I think there's a lot of stuff that could be used. So yeah, you never know, maybe in 10 years that will be what we're doing.
Yeah. So for now, I think if I am trying to look at what outcome measures I can derive from it, I will have to be looking at the literature or speaking to like colleagues like yourself, or going on like that quality improvement international software and asking, right? Like that's kind of how.
Yeah, I think it's a tough sport to do as an individual, having done this for many years, and I think where having some guidance and mostly just mentorship around how hard it is, but also ways to kind of clear out the path and make it more feasible, because we're all extremely busy, right? And both patients and us don't have a lot of time. So how can we start with our best measure, the one that's feasible for both the patient and the clinical team? And I think most importantly, how do we build a structure to review it every 6 months or 12 months? Because often we measure and then we don't ever look at it again. And that's kind of wasteful. So I think it's that we're not clinical experts, but the clinical experts often know, and patients have communicated, but how can we make this realistic? Because that's the day-to-day application. The ideology sounds great, but unless you can actually do it, it's tough. And that's why I suggest, if you're super interested, check out the iCHOM education, because it's really also very inspiring to hear people in third world countries do stuff that's way better sometimes than what we're accomplishing in our sort of developed healthcare systems.
No, that's fantastic. Thank you so much. Thank you.
Yeah. Do we have any other questions from the audience? I do think, Shannon, as you're chatting, the measures, this is even something for, a very small lab-based QI project. Like, they're so challenging to wrap your head around anything that doesn't just involve a number, right? Like, I can't imagine from the clinical side of things, figuring out how you're going to get the data that you need in an easy way. Like, obviously this can't be as simple as us just looking at number of events in the lab, but yeah, it's, I think, the biggest challenge that I have in the QI sort of aspect of this. Doug, you put your camera on, that always means one thing. You're ready.
Yeah, no, I'm not. But actually, I did want to say, Shannon, how much I appreciate the work that you're doing. And I particularly liked the fact that you're looking at this from a provincial perspective as well, with your various studies. I wondered, so as we deal year over year with continued increase in costs for plasma protein products in the vicinity of $150 million last year. I think one of the things that I've always felt, we always, I think there's this sort of concern emanating from the Ministry of Finance, let's say, about the continued year over year increase in costs. And I've always believed that if we can demonstrate value in terms of improved outcomes, that we can reassure the Ministry of Health that things are moving in the right direction. I guess I'm not sure what my question is, but I think I'd like to understand if it's feasible for us to do something on a very large scale, provincially, to look at sort of value-based healthcare for products like subcutaneous immune globulin and that sort of thing. Do you think that's feasible?
Yeah, I think it's feasible if we bake it into a prospective effort. I think where it's really hard, as you all know, is to try and look back or look at charts and kind of make those assumptions. So what's feasible, I think, though, in a day-to-day practice is different than what we see in the research publications. And I think what we struggle with is that engagement with patients, because they're going to give you great data if you ask in the right way and if you share it with them. If you just throw questions at people and you never tell them, like, or review with them or thank them, they're not going to do it. It's just such a fact of life. And the more people have portals and surveys, the more it's going to be a problem. So, I mean, I think we've got, certainly our hemophilia clinic does EQ5D5L, the one that I mentioned. We do that at every visit where possible. We're not forcing patients to do it, but if feasible, and we try to review it with them every time. I know some groups who are working with the sub-Q IVIG, in particular that transition between IV and sub-Q, are measuring standardized outcomes. And we're working with them to try and leverage that data in a way that's kind of visible to patients. And I think that's what's going to help highlight your point, because when we can show that people are living healthier and better, they're less likely to use emerge admissions. They're less likely to consume healthcare. But that invisible side of it's so hard conceptually for ministries to see when in front of them is the bill, right? But I think we're on the way, and our team at Providence has been trying to build those structures so that clinicians don't have to do this on weekends or evenings at the side of their desk, and we can help them get it working prospectively. But if we don't use it provincially or leverage it, or even use proxy data that we know exists, but we can't get access to it on a provincial level, then we can't really get very far about that complex relationship between therapeutics and care, because care is a lot of it. The therapeutics require the clinician and the patient to use it well, and also the expenditures. Then we can kind of get somewhere.
Thank you.
Thanks. Now, I just have a question, is because you're the physician lead for value-based healthcare at Providence. Are there physician leads for this at other health authorities?
So no, not yet, as the answer I'd like to give. I think we have, because we are going into this new St. Paul's Hospital, we have this opportunity, and it became a strategic objective to practice value-based healthcare intersected with our quality and safety pillars. So it was this kind of opportunity, and we had a couple of us who did sort of advanced level training involved in the organization. So it sort of happened. I'd love to say we're practicing it everywhere, but it's like retooling this is kind of like that, pulling that cart. We're still a little bit stuck in the dirt, but we're trying to take off some of those rocks and make a smooth pathway for others. I think, though, until we have kind of ministry level or high level CEO engagement in this philosophy, it will be hard to have both physicians and then teams. So in our team, we have data analysts, all part-time, QI expertise. We have informatics expertise, which has turned out to be one of our biggest piles of work. And so integrating all of those things together across the organization with this sort of outcomes and cost ideology is really hard. But I think this is what organizations who've succeeded at doing this, US General in Montreal and the CS system, they're way ahead of us. So it's going to happen. And it's just, I think, needs that level of support and buy-in. And I'm so proud of Providence for having it. And we're hoping to sustain it in a more formal way into the new hospital and help teams really do some of this really important work.
Yeah, that's wonderful. The comment in the chat from Matt Yen. It'd be nice to include these into our renewal PPOs for outpatient IVIG, SCIG, RBCs, the quality of life scores, days off work, etc. Just baking it into those, something that we can maybe a bit control in the lab, because throughout your presentation, I'm like, okay, we're always at one step away from the patient. So while, value-based healthcare, patient-centered care, the principles all elude me a bit of what we can do because we're not interacting with them, right? So, but yeah, wheels are turning for sure.
Well, I'm just like sometimes we do get those orders, especially there has been studies looking at like the outpatient world for transfusion is really difficult. Like, what are we really measuring? And I know at Sunnybrook they've tried to measure, I think they're using quality of life scores at higher thresholds than we're comfortable with, like 100, 120, and the UK did the same. And so sometimes we get those that come across our desks, and rather than just say it's outrageous and no, I usually call, and usually there's a story. Like my patient just wants to be able to look after their grandkids, allow their parents to then go to work. Like these are things that sometimes I will let go, but I always ask for follow-up. Like, did the intended effect of what they were aiming for actually happen?
I'm so happy to hear that, Matt. And Anne gave you a heart. So I think there's lots of people on the call who believe that the impact can be more than what we're able to measure in our systems. And I do think maybe often we don't know how to pick the right tool, or we extrapolate one that's been used in research because that's just seems like a good idea, and it is, except if we can't translate it into day-to-day life for these patients and find out a relatively seamless way of them providing this information and then doing something with it as a system when we get it. I know that I hope no one's on the call here for this, but one example that I think is when we don't use the data is our annual renewals for emicizumab for our hemophilia population. We know we have to put the number of bleeds, the number of acute care encounters used, and I'm not sure anyone ever does anything with that data. I'm like, well, why am I spending time to go through the chart and give this when no one's using it? And so you tend to want them to just, put something in, but that's what patients are going to feel like if we're not actually showcasing and communicating back how that information has taught the system something. So that's one tiny example that kind of bothers me when we do ask, is we should use it.
Sorry, it's having trouble coming off mute. Yes, I agree with that wholeheartedly. Like asking for data that we are not looking at all, or even to make the decisions in the current case, but also if we're collecting data that we're supposed to be using to measure stuff, but we're not using it like that. We don't want to waste anybody's time, right?
And it's totally not a bad intention. Like everyone does it with good intentions. I think it's just that we're so busy. And when we talk about that bucket of waste, what could we get rid of? And that's sometimes how we make space for teams to do some of this work. It's like, why are we doing this still? We did that 10 years ago, but we just kept doing it, but we don't actually do anything with it. So can we give ourselves permission to take that rock out of the cart? And that might enable us and give us a bit more space. So I think that sort of thinking is helpful, and that can be in any environment, whether it's patient facing or not.
Yes, you're right. Actually, something that stimulated me at CSTM last year is lots of centers aren't reporting their minor transfusion reactions anymore. So the febrile non-hemolytics or the minor allergics, and I was like, oh, why do we do that? Lots of other people aren't doing it. So it's all these things, food for thought of things we do just because that's how we do things, right? We are at time though. So thank you so much for this wonderful presentation. Absolutely love it. A bit different from our normal transfusion medicine rounds, but we love to have the variety. Thank you, everybody. And please do the evaluations for your attendance and then obviously to evaluate our speaker. And we'll see you next month. The date will change. I'll send it out soon, actually. It won't be the second or third Thursday of the month just because of the speaker availability. Thanks, everybody. Have a great one.